Welcome to The Critical Edge, the no-nonsense podcast breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
Glad to be here.
So if you're a trauma surgeon operating in a high-stakes, fast-paced U.S. clinical setting today, you're constantly dealing with chest trauma.
Oh, absolutely. Every single shift.
Right. And what's wild is, I was reading this, in roughly 3000 BC, the physician who wrote the Edwin Smith Papyrus dedicated a full 25% of his medical cases to chest trauma.
Wow, 25%?
Yeah, a quarter of his cases. And 5,000 years later, trauma surgeons standing in level 1 bays across the United States are looking at the exact same mortality attribution.
That is just, it's a sobering statistic, right?
It really is. The armor has evolved, from bronze breastplates to steering columns and Kevlar, but our fundamental vulnerability, our respiratory mechanics, remains exactly the same.
Yeah, the human pleural space is just as intolerant of disruption today as it was in antiquity.
Exactly. So today, we are doing a comprehensive breakdown of the seminal chapter, Thoracic Wall Trauma and Pleural Space Injuries, by Zhang, Hauser, and Livingston.
A fantastic text.
It really is. We're going to arm you, the listener, with actionable clinical pearls, evidence-based recommendations, and the nuanced pathophysiological insights you need to optimize the management of blunt and penetrating chest trauma.
Because our goal here is to basically bridge that ancient, unforgiving anatomy with modern multimodal trauma care.
Right. So let's just jump right into the epidemiology and the mechanisms, because the baseline numbers really set the stakes here.
They do. Like you mentioned, thoracic injuries account for 20 to 25% of all trauma deaths.
Which is huge. And the text references this highly granular retrospective review from a major U.S. Level 1 trauma center. They looked at over 7,000 patients.
And what's fascinating is, out of that massive cohort, 10% presented with rib fractures.
Right. And of that specific 10%, 94% had associated extrathoracic injuries.
Which tells you right there, an isolated rib fracture is almost a myth in high-energy trauma.
Exactly. And the overall mortality rate for that group was 12%. Fully half of these patients required either operative intervention or an extended ICU admission.
Yeah, because the mechanisms we're talking about, high-speed motor vehicle collisions, falls from height, severe direct blows, they deliver a massive kinetic payload.
Right, and that leads us to a metric that I think completely alters clinical triage, which is the rule of 3.
Oh, the rule of 3 is critical.
The authors are so definitive about this. Finding greater than 3 rib fractures on a plain AP chest film in an adult, it's not just an indicator of bone failure.
No, it's a definitive marker for solid visceral trauma.
Right. It elevates the mortality risk, and crucially, in hemodynamically stable patients, it literally doubles the rate of intra-abdominal injuries detected on a CT scan.
And to understand why that 12% mortality rate exists in a modern cohort, you really have to look at the physics of the trauma.
Yeah, break that down for us.
Well, when a patient dies following blunt chest trauma, it's exceptionally rare that the actual fracture of the cortical bone is the lethal event, right?
Right. It's rarely just the bone.
Exactly.
Huh?
The mortality is almost entirely driven by the associated multisystem organ failure and the underlying parenchymal destruction.
So we're talking about the pulmonary contusion blossoming underneath those fractured ribs.
Yes, and that localized inflammatory response basically primes the lung for ARDS, plus the retained secretions that inevitably progress to a nosocomial pneumonia.
Okay, let's unpack this for a second. If the chest wall is functioning as the body's crumple zone in an MVC, are we paying way too much attention to the crumpled metal like the ribs themselves and not nearly enough attention to the engine block?
The engine block being the viscera.
Right. Are we getting tunnel vision, counting cortical breaches on an X-ray, and missing the sheer wave that just went through the liver and spleen?
That crumple zone analogy is the exact physiologic reality. It's spot on.
Because the energy has to go somewhere.
Right. When you have 4, 5, 6 ribs fractured, that kinetic energy has translated violently through the periosteum, across the pleura, deep into the lung parenchyma, and right across the diaphragm into the solid organs.
Which is why the rule of 3 mandates a strict deviation in clinical pathways.
Absolutely.
Yeah.
If a hemodynamically stable patient comes in with 4 rib fractures on a plain film, you cannot just observe them in the ED and send them home with some oral NSAIDs.
Right. That finding automatically triggers a heightened index of suspicion. It mandates an immediate contrast-enhanced abdominal CT to evaluate for splenic or hepatic lacerations.
Because, as the data shows, the incidence of intra-abdominal injury doubles. It literally alters your triage.
It's often a hard indication for trauma center transfer from a critical access hospital, right?
Exactly. You aren't transferring them because a bone is broken. You're initiating that transfer because of the massive physiologic debt that specific level of force guarantees.
So, knowing that the mechanism of injury dictates the structural damage, we also have to recognize that the exact same kinetic force applied to vastly different anatomical canvases yields radically different
Oh,
reality.
without a doubt, patient demographics change everything.
Let's look at the extremes of age. A 40-mile-per-hour lateral impact in a 25-year-old is a completely different pathophysiologic trajectory than that same impact in an 85-year-old.
Yeah, let's start with the pediatric population. The biomechanics there are totally unique.
Because their chest walls are so compliant, right? Highly cartilaginous.
Right. They're incredibly resilient. They're designed to deform. They can absorb and distribute tremendous kinetic energy without losing gross structural integrity.
So they basically bow inward, compress the interthoracic structures, and then recoil.
Exactly. So rib fractures in infants and young children are statistically rare.
Mhm.
But when they do happen,
It's a massive red flag.
a blaring red flag. It strongly indicates either an overwhelming, massive intrathoracic crush injury, meaning the underlying lung and myocardium were just subjected to a devastating compressive load.
Before the bone finally yielded.
Right. Or, very ominously, it points to non-accidental trauma, child abuse.
So finding a single rib fracture in a toddler is essentially like finding a canary in a coal mine. It instantly alerts you that the environment is deeply dangerous.
That's perfectly said. The clinical pathways have to be aggressively dual-tracked there. You're doing damage control resuscitation for occult contusions while simultaneously activating child protective protocols.
Because you have a strict medico-legal duty there.
Absolutely.
Yeah.
Especially if you see acute fractures with vague mechanisms or fractures at varying stages of healing on the radiograph,
Right, but then on the exact opposite end of the spectrum, we have the geriatric population.
where the pathophysiology is totally inverted.
Right, because of osteopenia and advanced osteoporosis.
Exactly. Over decades, that costochondral cartilage ossifies, bone mineral density plummets, and the thorax becomes this rigid, highly brittle cage.
It loses all capacity to deform.
It just shatters upon impact. So a simple ground-level fall, which the triage algorithm might flag as low acuity, frequently yields multiple displaced fractures.
And frailty multiplies that insult exponentially.
Yeah. The correlation between the absolute number of fractures and the mortality rate is distinctly amplified in patients over 65. Their baseline functional residual capacity is already compromised.
So while finding multiple fractures in an osteopenic 70-year-old might seem like just a standard Tuesday night admission for a busy level 1 bay.
It's really not. The mortality curve is brutally steep.
Right, because of the pain hypoventilation cascade.
Exactly. Intense localized pain leads to splinting, which drives dependent atelectasis, which halts mucociliary clearance.
And boom, fatal nosocomial pneumonia within 48 to 72 hours.
You have to initiate aggressive pulmonary hygiene protocols immediately. You cannot allow routine frequency to breed clinical complacency.
Which perfectly transitions us to the diagnostic workup. Because to manage either extreme, you first have to identify the exact scope of the damage.
And the text practically begs us to abandon historical physical exam dogma here.
Oh man, the tracheal deviation myth.
Right. The classic teaching that tracheal deviation is the hallmark of a tension pneumothorax. It's effectively a myth,
You rarely ever see it clinically.
even with gross mediastinal shift on imaging. Trying to palpate the trachea in an obese patient who is strapped into a rigid cervical collar is practically impossible.
And auscultation, I mean, it has high specificity. If you hear absent breath sounds, it's real, but terrible sensitivity.
Yeah, and percussion is completely useless in a noisy ED when multiple providers are yelling out vitals and monitors are alarming.
So our reliance shifts entirely to imaging. But even there, the standard supine AP chest radiograph is notoriously inadequate.
It's terrible for ruling things out. It misses 20 to 35% of pneumothoraces.
And it requires a minimum accumulation of 200 to 300 milliliters of blood just to blunt the costophrenic angle and show a hemothorax.
Which is why ultrasound, the EFAS, is so critical now. It's highly effective for pneumothorax if you look for the lack of lung sliding between the second and third intercostal space.
But the undisputed gold standard remains the multi-detector CT scan.
Oh, for sure. The modern 64 or 256 slice CT scanners are infinitely more sensitive.
They identify an average of 2 to 3 additional rib fractures compared to a plain film.
They give you a high-definition 3D topographic map of every microfracture and trace contusion.
But the authors bring up this really fascinating clinical
The
paradox.
CT-only dilemma.
Right, CT finds way more fractures and reveals these CT-only pneumothoraces, which have an incidence rate of 2 to 8%.
Right.
But pulmonary morbidity like pneumonia and mortality only statistically correlates with injuries severe enough to be seen on a plain chest x-ray.
Exactly.
So here's where it gets really interesting. We have these million-dollar scanners finding every microscopic air bubble in the pleural apex. Are we suffering from information toxicity?
That's the perfect term for it.
If a pneumothorax is only seen on CT, do we actually need to put a piece of plastic in the patient's chest? I mean, are we treating the patient or are we treating the pixel?
That specific dilemma dictates modern trauma management, and the guidelines in the text are highly nuanced.
What do they recommend?
Well, if you have a hemodynamically stable patient ventilating comfortably on room air, with a trace anterior pneumo seen only on CT observation, is completely safe.
So you just do serial plain films at 6 and 24 hours.
Right, just to confirm it isn't expanding, subjecting that patient to a 28 French chest tube through their intercostal muscle introduces unnecessary pain and infection risk for zero clinical benefit.
However, that paradigm aggressively shifts depending on the polytrauma context, right?
Absolutely. If that exact same patient has a severe traumatic brain injury where you must strictly avoid hypoxia,
Or they're in hemorrhagic shock.
or, most critically, they are heading to the operating room for a laparotomy or orthopedic fixation.
Ah, right. Because anesthesia will secure the airway and initiate positive pressure ventilation.
Exactly. The observation pathway is instantly abandoned. Rapid tube thoracostomy becomes mandatory.
Because the moment the anesthesiologist bag that patient and applies positive end expiratory pressure, they are actively forcing air through the injured visceral pleura.
You'd convert a totally benign 2 mm air lake into a lethal tension pneumothorax while the patient is fully draped, paralyzed, and surgically inaccessible.
Wow, so the anticipated physiologic trajectory dictates the intervention.
You have to anticipate the mechanical forces the lung will face over the next 12 hours.
It makes total sense. Now, let's say the CT reveals a battered, multi-fractured chest wall, but no pneumo that needs immediate decompression. The absolute priority becomes keeping the patient breathing.
Which means an uncompromising multimodal approach to pain control. The text establishes pain control as the absolute linchpin of non-operative management.
Because inadequate analgesia guarantees hypoventilation. The patient takes shallow, splinted breaths to avoid the agonizing friction of the broken rib ends.
Which directly leads to atelectasis, pneumonia, and ventilator dependence.
So what's the pharmacologic protocol here?
It's highly structured. We're looking at scheduled acetaminophen, and they specifically note that the IV formulation is vastly preferred over enteral in the critical care setting for consistent bioavailability.
Right. And then you layer on NSAIDs like ketorolac, if renal function allows.
Plus gabapentin for the neuropathic pain from the crushed intercostal nerves.
Yeah.
Muscle relaxants like cyclobenzaprine for the chest wall spasms.
And very judicious, low-dose systemic opioids.
Right, but the real heavy hitters are the regional anesthetics.
Epidurals versus paravertebral blocks.
Exactly. The text cites pivotal literature here. McCarthy and colleagues showed that thoracic epidurals vastly improve dynamic pulmonary mechanics. An incredible 85% of their epidural cohort required zero parenteral narcotics.
That's amazing. And Bolger's prospective work showed epidurals literally halve the number of ventilator days.
Yes, but Bolger's data also revealed a massive logistical hurdle. Over 50% of blunt trauma patients have clinical exclusion criteria that completely prohibit placing an epidural.
Right, because historically we relied on systemic opioids, which is a double-edged sword. You blunt the pain, but you cause a dose-dependent depression of the central respiratory drive.
You mitigate the pain, but actively worsen the hypoventilation.
Which is why regional is so critical, but it seems like epidurals are the Ferrari of pain control.
That's a great way to put it.
I mean, amazing performance, unparalleled analgesia, but incredibly finicky, and you just can't drive them on a bumpy road.
You really can't. In a polytraumatized patient, it's a very bumpy road. If they have an uncleared spine fracture, the epidural is strictly contraindicated.
Or they're coagulopathic from massive transfusion.
Or if you need to start low molecular weight heparin for DVT prophylaxis. Placing an epidural risks a catastrophic spinal epidural hematoma. You could leave the patient permanently paraplegic.
Plus the bilateral sympathectomy causing transient hypotension.
Right, which is a nightmare if you're worried about occult intra-abdominal bleeding.
So if the epidural is the Ferrari, is that why paravertebral catheters are taking over? Are they basically the all-terrain vehicle of the trauma ICU?
That is an incredibly accurate depiction. The text heavily emphasizes that continuous paravertebral blocks are a profound alternative.
Because you're using ultrasound to place a catheter directly into the paravertebral space, right next to where the nerves exit.
Exactly. You run a continuous infusion of bupivacaine, and you get this dense, unilateral somatic and sympathetic blockade of just those specific dermatomes.
And because it's outside the central neuraxis, you don't get that profound bilateral sympathectomy and hemodynamic collapse.
You don't need exhaustive spinal clearance. You can use them much more liberally with chemical DVT prophylaxis without the paralyzing fear of a spinal hematoma.
And no risk of epidural abscess or meningitis.
Right. It's Ferrari-level analgesia on an all-terrain chassis.
I love that. But, when chemical pain control isn't enough to overcome the structural collapse of a flail chest, the trauma surgeon has to consider mechanical stabilization.
The surgical stabilization of rib fractures, or SSRF, this is a fierce controversy right now.
The historical context the authors provide is wild. In the 1940s and 50s, surgeons managed flail chests with external traction.
Literally using towel clips to pull the flail segment outward and tying it to weights.
That sounds brutal.
It was largely abandoned once positive pressure ventilation came around, which acts like an internal pneumatic splint.
But now, operative SSRF is seeing a massive resurgence. The hardware has evolved from simple wires to these modern anterior plating systems with bicortical screws, intramedullary splints, U-plates.
Even absorbable polylactide polymers.
Yeah.
And we're seeing widespread integration with VATS, video-assisted thoracoscopic surgery.
So you can map the fractures from inside the chest and use minimally invasive incisions. But despite all these cool titanium toys, the clinical data is highly debated.
Highly debated. The text cites a landmark randomized prospective trial by Marasco and colleagues. They found absolutely zero difference in ventilator days or long-term quality of life scores between operative and non-operative management of flail chests.
Zero difference, wow. But then Chillon's research indicates that unfixed lower rib fractures predict worse patient-reported physical limitations.
True, but then you look at the large-scale data from the Victorian State Trauma Registry, and again, no statistical benefit in pain reduction or functional scores at 24 months for patients who underwent operative fixation.
So what's driving this controversy?
It's about identifying the true primary driver of the respiratory failure.
Because a flail chest's 3 or more consecutive ribs fractured in 2 or more places moves paradoxically.
Right, it pulls inward on inspiration, outward on expiration, it degrades tidal volume. But the profound hypoxemia isn't usually just from the mechanical paradox.
It's from the underlying pulmonary contusion.
Exactly. The blunt force required to shatter multiple ribs in 2 places guarantees the lung tissue beneath is heavily bruised, hemorrhagic, and edematous.
So if you fix the ribs, does that heal the lung?
Not at all. That's the hard physiologic truth. You can achieve a technically flawless bicortical plating, completely restoring the chest contour, but the underlying lung remains heavily contused. The inflammatory cascade still triggers ARDS.
The authors mention the surge as, quote, driven in part by industry forces. We have whole societies popping up just for chest wall instability. So what does this mean for the surgeon? Are we plating ribs just because we finally have the toys to do it? Or is there a true physiological imperative?
Navigating this requires immense clinical discipline. The hardware is a marvel, especially using VATS to minimize surgical trauma. But patient selection is paramount.
So who actually benefits?
A highly selected cohort. Patients with massive, grossly deforming chest wall defects. Or those failing to wean from the ventilator due to pure mechanical instability without severe underlying contusion. Or patients with intractable pain from severely displaced overriding fragments.
But if they have a totally destroyed lung underneath?
Then plating the chest wall is like putting a pristine new roof on a house with a crumbling foundation. The structure will inevitably collapse regardless of the roof.
You have to distinguish between mechanical ventilator failure and parenchymal ventilator failure.
Exactly. If it's parenchymal, applying titanium plates just adds the morbidity of a major operation.
Okay, so whether or not you plate the ribs, you must manage the pleural space beneath them. Which brings us to the bread and butter of trauma surgery. Tube thoracostomy.
The absolute bedrock procedure.
Let's start with the most immediately lethal presentation, the tension pneumothorax.
The classic one-way valve effect. Air enters the pleural space on inspiration but can't escape on expiration.
Which causes gross mediastinal shift and profound cardiovascular collapse. And the treatment is immediate needle decompression.
But the text highlights a major data-driven shift in clinical practice guidelines here regarding the anatomical approach.
Yeah, we were all taught to blindly insert a large bore angiocatheter into the second intercostal space at the mid-clavicular line.
Right. But extensive military experience, civilian body armor, and rising baseline BMIs have shifted that. Now, the recommended approach is the fifth intercostal space at the mid-axillary line.
Because the chest wall musculature is significantly thinner there.
Exactly. A tension pneumo kills via obstructive shock, not hypoxia. The pressure compresses the vena cava, venous return drops to zero, and the patient arrests.
So if your needle isn't long enough to breach the pleural space through thick anterior chest tissue at the second intercostal space, the patient dies while you think you've treated them.
Exactly. That's why the shift to the fifth intercostal space is vital.
And when we transition to definitive tube thoracostomy, the authors are highly prescriptive. Insertion at the fifth or sixth intercostal space, mid-axillary line.
They strongly advise infiltrating the parietal pleura with 1% lidocaine for immediate onset and 0.25% bupivacaine for hours-long analgesia.
And they issue a massive, uncompromising rule. Never use the rigid metal trocars that come packaged with the tubes.
Never. You must perform a blunt digital sweep with your finger to confirm entry and ensure there are no pleural adhesions binding the lung to the chest wall.
Then you advance the tube, checking the 10 to 12 centimeter depth mark at the skin level.
To guarantee the last fenestration is fully inside the cavity without kinking against the apical pleura.
And finally, the 360-degree rotation test to confirm it isn't hung up on anything.
It's basically a pilot's pre-flight checklist.
It really is. And for a hemothorax, the fluid dynamics are crucial. The goal isn't just to drain blood, right?
No, the paramount objective of a 36 French chest tube is to rapidly re-expand the collapsed lung, so the visceral pleura firmly opposes the parietal pleura.
Because that mechanical apposition physically tamponades the low-pressure bleeding.
Right. If you fail to get full expansion because of a retained clot or a kinked tube, they'll just keep bleeding.
And the text outlines hard indications for an emergent thoracotomy. Greater than 1 liter of immediate blood return, or greater than 200 milliliters per hour for 4 consecutive hours.
And if they're bleeding that much, the authors discuss the safety of autotransfusion, collecting that sterile pleural blood and infusing it back into the patient.
Which is an elegant resuscitation strategy, especially if the blood bank is depleted.
Very safe and highly effective.
Now, I want to pose a highly realistic 3 a.m. trauma bay scenario based on the text's strict rules.
Let's hear it.
Suppose a junior resident running on pure adrenaline inserts the tube way too far. The post-procedure chest x-ray clearly shows the tube abutting the apical pleura, bending sharply, and kinking right at the most proximal hole.
It's useless at that point.
Right, so the instinctual reaction is just to cut the silk suture, pull the tube back 3 or 4 centimeters so it straightens out, and resecure it. Why is that an absolute violation of surgical principles?
It is a non-negotiable violation because of basic microbiology. The text corrects this in the strongest terms.
Break it down for us.
The moment that chest tube is inserted, the proximal portion of the plastic that remains outside the body is exposed to the highly contaminated ambient environment of the trauma bay.
The blood, the non-sterile gloves, the air.
It is definitively colonized. If you pull that tube back even 1 centimeter, you are actively dragging a colonized segment of plastic directly across the sterile threshold and into the pleural cavity.
You are practically guaranteeing a catastrophic post-traumatic empyema.
Exactly. So if a tube is malpositioned, kinked, or accidentally pulled out a bit during a transfer, you cannot execute a half measure. You must completely remove it, reprep, redrape, ideally pick a new adjacent intercostal space, and insert a brand new sterile tube.
No half measures in pleural management. You contaminate it, you replace it.
Exactly.
Okay, let's pivot. While the ribs and pleura dominate the picture, we have to systematically evaluate the other critical bony structures encasing the chest. The bony sentinels.
Sternal fractures, scapular fractures, and clavicular fractures.
Let's start with sternal fractures, mostly unrestrained drivers hitting the steering column. 95% are non-operative, but the text mandates a baseline ECG. Right.
Yes, to evaluate for blunt cardiac injury. You're looking for arrhythmias or a new right bundle branch block that indicates a right ventricular contusion.
But scapular fractures, that represents a completely different echelon of kinetic energy.
Oh, absolutely. They occur in only 1 to 3% of blunt trauma presentations, but an astonishing 80 to 98% of these patients have severe life-threatening associated injuries.
Because it requires immense force to shatter a scapula.
Right. The scapula is heavily armored. It's enveloped by thick muscle, the trapezius, the latissimus, the rotator cuff, and it's highly mobile. It glides and deflects force.
So to actually fracture the body or the spine of the scapula, the kinetic transfer borders on the limits of human survivability.
Which is why a scapular fracture is a giant flashing red light warning the trauma team of underlying neurovascular and thoracic devastation. It's never just an isolated ortho problem.
And the most extreme manifestation of this force vector is scapulothoracic dissociation.
A catastrophic traction injury. The entire shoulder girdle is violently pulled away from the axial skeleton.
The data here is terrifying. 81% suffer a complete brachial plexus avulsion, and 88% have a complete disruption of the subclavian or axillary artery.
It's functionally an internal closed amputation of the upper extremity. The limb is often completely devascularized and insensate. The text notes this frequently necessitates a primary four-quarter amputation just to save the patient's life.
Incredible. And finally, the clavicle. 80% occur in the middle third of the shaft. And the authors heavily cite the UK clavicle trial to settle the operative versus non-operative debate.
Because the clinical predictive value regarding long-term morbidity is shifting rapidly here.
Right. So at 3 months, the non-union rates for displaced midshaft fractures were roughly equivalent 28% for operative versus 27% for non-operative.
But look at the 9-month follow-up.
That's where it violently diverges. The non-union rate plummeted to 0.8% for the operative group, compared to a staggering 11% non-union rate for those managed non-operatively with a sling.
Which completely shattered the prevailing orthopedic consensus. For generations, the standard of care was to just put them in a figure-of-8 sling and assume it would remodel.
So if a fractured scapula is a flashing red light for acute devastation, is a displaced midshaft clavicle fracture essentially a slow-burning fuse for chronic disability?
It is the definition of a slow-burning fuse.
Yeah.
If you look at the biomechanics, the lateral fragment drops inferiorly and rotates medially due to the pec muscles pulling it.
While the proximal fragment gets pulled up by the SCM.
Right, so if it heals in a foreshortened, malunited position, or fails to heal entirely, like we see in that 11% non-union rate, the functional consequences are severe.
Chronic shoulder pain, cosmetic deformity.
And most critically, a significant risk of delayed thoracic outlet compression. The foreshortened bone literally impinges on the brachial plexus cords and the subclavian vessels underneath.
Which is why the orthopedic community is shifting toward early operative fixation, using intramedullary flexible fixation or superiorly placed locking plates.
Right. As supported by the Cochrane reviews and the UK clavicle trial, you accept the small immediate risks of surgery to permanently extinguish that slow-burning fuse.
To prevent a lifetime of functional deficit makes perfect sense. But chronic disability from a malunited bone is one thing. Chronic, unchecked infectious complications inside the closed chest cavity are acutely, rapidly lethal.
The complications are where trauma surgeons really earn their keep.
Let's navigate the Q&A section of the text looking at 3 specific scenarios. Scenario 1, post-traumatic empyema. The true incidence is around 5%.
And it progresses through very distinct stages. Exuded effusion to loculated transudative fluid, and finally a thick, organized fibrotic rind.
And the treatment requires aggressive escalation from tube drainage to intrapleural fibrinolytics like TPA and DNase to VATS, and finally a full open thoracotomy and decortication.
We have to focus intensely on how this forms because this specific complication haunts trauma surgeons.
Right. The genesis is almost always a retained, inadequately evacuated hemothorax, isn't it?
Exactly. Blood pooling in the dependent pleural space at core body temperature is a perfectly optimized, nutrient-rich culture medium for bacteria.
Whether from the trauma itself or the chest tube.
Yeah. If you fail to evacuate that blood completely, fibroblasts migrate into the clot within days. They lay down dense fibrin strands, creating complex loculation.
Those walled-off, honeycomb-like pockets that a single chest tube can't possibly drain.
And if left unchecked, the exudate aggressively organizes into a thick, leathery, highly vascular fibrous rind that entirely encases the visceral pleura.
Which physically traps the lung. It tethers it to the hilum and prevents it from expanding, no matter how much positive pressure the vent applies.
Trapped lung syndrome. The patient becomes intensely septic, hypermetabolic, and permanently ventilator dependent.
Which is precisely why the modern standard of care mandates early CT scanning to identify retained blood, followed by early VATS to physically evacuate the clot before the rind forms.
You have to surgically break the cycle early.
But when they present late, you're forced to do a formal decortication, and you're meticulously peeling this dense rind off the fragile visceral pleura.
It's an incredibly bloody, grueling operation.
The text makes a deeply fascinating observation about the immediate postoperative period here. After a massive decortication, the post-op portable chest radiograph routinely looks terrifyingly worse than the pre-op film.
Oh, it looks like a complete, opaque, whiteout snowstorm.
Right. So how do you keep your clinical composure when you roll the patient into the surgical ICU and the film looks like a disaster?
You maintain your composure by strictly anchoring your decision-making to the clinical reality of the patient and actively ignoring the radiologic artifact.
Why does it look so bad?
Because during decortication, you are intentionally inflicting massive surgical trauma directly to the visceral pleura. As you strip that dense rind away, you strip away the mesothelial layer.
So you cause profound localized tissue edema.
Massive capillary leak, and inevitable minor alveolar hemorrhage across the entire surface of the lung. The X-ray is just capturing all of that immediate post-surgical third spacing and fluid shift.
But if you look away from the monitor and evaluate the patient,
Their physiologic parameters are drastically improving. Their dynamic compliance on the vent has certainly doubled because the lung is physically free to expand.
the sepsis-driven fever curve is breaking, the leukocytosis is trending down.
Exactly. The clinical improvement will always significantly precede the radiographic clearance. The surgical mandate is to treat the patient, utilize vigorous pulmonary toilet, and trust that the physiologic dead space will clear its edema.
Treat the patient, not the radiograph. Let's touch quickly on scenario 2, post-traumatic pneumothorax.
That's an air collection or cyst directly within the pulmonary parenchyma without a fistulous connection to the pleural space.
And the text says these generally resolve spontaneously once the patient is weaned from positive pressure ventilation.
Yes, they're usually benign.
But scenario 3, persistent air leaks. If a chest tube continues to bubble continuously for days or weeks, you have to rule out a major tracheobronchial tree injury via bronchoscopy.
And if that's negative, the text strongly advocates for early tracheostomy.
Because it significantly decreases the anatomic dead space and lowers the peak inspiratory airway pressures, allowing that peripheral alveolar leg to finally seal.
Exactly. It changes the pulmonary mechanics to favor healing.
This has been an incredibly dense analysis. Let's distill the core, high-yield take-home applications for the surgeons listening.
Sure. First, respect the physics behind the rule of 3 for rib fractures. It's a mathematically proven trigger for deep, solid organ injury and mandates a contrast-enhanced CT scan.
Second, abandon the supine plane radiograph as a definitive tool for ruling out thoracic injuries. Trust the CT, but exercise the clinical judgment to safely observe a CT-only pneumothorax based entirely on whether the patient is facing imminent positive pressure ventilation.
Third, prioritize multimodal opioid-sparing pain control, specifically deploying ultrasound-guided regional paravertebral blocks to actively prevent the cascade of hypoventilation and pneumonia.
Recognizing that plating ribs will never fix a hemorrhagic lung contusion.
Exactly. And finally, maintain strict, uncompromising surgical discipline in your chest tube technique to prevent retained hemothoraces and those grueling empyema decortications.
The overarching theme here is a profound respect for the delicate mechanics of the pleural space. From the Edwin Smith papyrus to our modern level 1 trauma bays, the physiologic margin for error is razor thin.
But by integrating these precise anatomical principles with modern diagnostic imaging and advanced regional analgesia, trauma surgeons can predictably interrupt that lethal pathophysiology.
Which leaves us with a final forward-looking thought to consider as you head into your next shift. As our imaging technology becomes infinitely granular, identifying submillimeter cortical microfractures and microscopic pneumothoraces that no previous generation of master surgeons ever knew existed, the greatest challenge for the future of trauma surgery won't be finding the injuries. It will be having the immense clinical discipline to know exactly which ones to safely ignore. Are we treating the physiologic reality of the patient, or are we simply treating the pixel? Thank you for joining this session of The Critical Edge. Keep your edge sharp.